So, without further delay, can I invite the Prof to speak to you? Thank you.
Great. Well, thank you hugely for that very kind, if undeserved introduction. It's really great to be here. And I think it's absolutely amazing what you have done with the charity. I think it fulfills a really important function for our patients, providing information and making them feel a little bit less lonely than they would otherwise do. So, and to have the knowledge that there's other people out there in a similar situation, and to be able to exchange experiences and ideas is a really valuable thing. So you should be hugely commended for doing what you do. And as a clinician, it makes my job easier, actually. So well done, and thank you for inviting me to be here this afternoon. It's a real privilege. And I'd also like to thank all of my colleagues for being here to share this event, and in particular Moira for giving, I think, what everybody would agree was a really breathtakingly inspirational presentation, where the idea of hope was right the way through it, and I think you're a sort of walking example of somebody that's never sort of lost that hope, and I think you're an inspiration for all of us. So thank you for that. So what I'm going to try and do over the next just a few minutes, I'm not going to ramble on for too long, is I've been given this job of trying to pull things together, if you like, owning your journey, pulling the threads together. And I'm a researcher. I'm going to try and focus a little bit around research as well, and try and give my own perspective on research and where clinical trials kind of sit in the research spectrum, and also try and share with you some of the broader benefits of research, which I can see from my perspective, and convince you that there's benefit to being part of clinical research above and beyond what's immediately apparent. So here we go. We're all corrupt, and I need to declare my level of corruption, which is what this slide's all about. My get out here is that because these companies are all competing with each other, that cancels it out. So, but actually, seriously, there's people like me rely very heavily on industry for helping me to do my job. So industry. Pharma companies, they fund a lot of, not just their own research, they fund a lot of academic research, and provide drugs for non-industry studies that allow us to do non-commercial trials. So this is actually fundamentally important to non-commercial research as well. And of course, the companies also can provide sort of travel costs for conferences and spare the public purse those costs. But it's important for me to be transparent with you about all this. Okay, so owning your journey. So this is kind of a reiteration of what's already been said, but I thought I'd just sort of go through it again, just to pull it together and kind of reassure you that from my side of the desk, as it were, I strongly endorse the idea of kind of patient power, because I think it's by having that ownership of your disease and that knowledge that goes along with it that we make good decisions. It's a team. I was talking to Moira about this earlier. We work as a team, so we are as sort of clinicians are there to lay out the options, advise. Nursing staff are there to support, family, friends there to support. The most important person in the team is the patient, of course, who owns the disease and all decisions around it. So that's the kind of concept. So, but to be in that position, you need to have information. So you need to be informed. So my advice to everybody is, and it can be a bit scary, and some of the data you see is frankly misleading because it's old or just wrong. Find good sources of data, reputable sources of data, and make it your business to find out about your disease. And in doing so, very often it becomes less scary than it was when you were kind of operating in a sort of well, compared to how it would feel if you were operating in a sort of vacuum of ignorance. So be informed, ask questions. There's no such thing as a stupid question, and you should remember that. And if anything's unclear, you know, speak up. And you know, we want you to speak up. We want you to make sure, we want to make sure that you understand the issues that we have to discuss. And again, that's how good decisions are made. Excuse me, I'm going to take a sip of water. Okay, all treatments have desired effects and unwanted effects, and there's always a balance. There's always this balance going on. So it's important when you're considering different options to think of it like that. What are the pros of the option? What are the cons? Same thing for the other option. How do those things stack up? So, you know, there's always two sides to everything, and it's important to bear that in mind. And very often there's no absolute wisdom. There's no single right way of doing things. And often the right way forward for you will depend on where your priorities are in life. So, for example, you know, we've got this typical current dilemma that we encounter. It's like bread and butter for us. It's, okay, which, you know, did you go for a BTK inhibitor or venetoclax-based treatment? And, of course, one is long-term, the other is fixed-term. So, and one is a bit of a hassle to start off with, and the other's a bit more straightforward. So all these things kind of factor in, and you need to kind of decide what your priorities are. Would you rather have a treatment that kind of has a finite duration and finishes after a year, and you're prepared to put up with that little bit of hassle at the beginning? Or would you rather keep it nice and simple, just start off simply, carry on? You know, would you feel more comfortable being on a long-term treatment? So that's all about being clear where you stand on particular issues like that. If you think you're being given advice which doesn't feel right to you, challenge it. Okay, speak up. We welcome that. We don't want you to just sit there nodding and end up in a situation that isn't the best one for you. So we actively welcome you to challenge us. Likewise, if you think we've forgotten something, because we're only human after all, remind us about it. Again, we work as a team, and that the teamwork only works when everybody feels confident to chip in and contribute. So please do speak up if you feel that something's not quite right. So we've touched on research, not more than touched on, we've gone through quite a lot of it. I hope, based on what you've heard so far, you've been convinced that there's a net benefit to taking part in research. It's not for everybody, and you know, we as clinicians advising people about research and nurses need to, you know, present a balanced perspective. But you know, I think if we forget to mention it, you ask about it, because there may be a study that's available to you which is right for you and works for you. So, and again, if we forget, mention it. There's, I guess, one of the issues I sort of see around me when I'm talking to people with CLL is this sense that, you know, it's easy to kind of lose control and you become sort of passenger in the whole process, and to some extent that's, I guess, a little bit inevitable. There are things you can do about it apart from what I've just mentioned and feeling part of a collective decision-making team. For example, you can look after your general health. That's something that everybody can do. You know, it's fair to say that if you've got a medical condition, the outcome is always better if you're in good physical and mental shape. So I think this is really, really important, and we've touched on it already, but you've got to think about these things. And that doesn't mean sort of going mad. It means just living a healthy lifestyle, having a healthy diet. And if you do that, you're doing, you know, the chances are that your background health will be good. And if you think there's something wrong, if there's a physical or mental health issue, get it sorted, because that will help you deal with the CLL more effectively. Very pertinent to today's meeting, the word support. Have a think about what you've got around you to support you. You know, going through a journey like CLL is, it's challenging at the best of times, and it can get very lonely, and you can feel isolated. So have a think about what you've got around you that can support you to feel less lonely and less isolated. So, and that can range from simply, family and friends, being able to chat to family and friends and share your anxieties. A problem shared is a problem halved. There's a lot of truth in that adage. And then there are more formal things. Obviously your local clinical team, the medics and nurses, should be able to provide a lot of support. And then, of course, there's this group and other sort of groups, not quite like this because this is unique, but other charities that focus on support. We've seen some of those mentioned already, but don't forget about it. Everyone needs to lean on someone or other. And finally, just be kind to yourself. It's a big deal having CLL at every stage of the journey, and you're going to feel, your life's turned upside down when you're given the diagnosis. We were chatting earlier, and, to many people it feels like a bereavement, the losing your old self. And you've got to kind of be in tune with that and just cut yourself some slack and realise that, life is going to feel pretty shitty for a bit, but it will get better, But just be kind to yourself, and if you feel you're overdoing it, tone it down a bit. I think Moira's presentation really eloquently captured that idea, and I'd strongly endorse what was said. So that's my kind of top tips, if you like. So the next little bit of the next slide is going to be about research, and in particular, clinical trials. Stella's given a very excellent summary of the sort of detail of various ongoing studies, so I'm not going to repeat all that. But what I'm going to do, I'm going to try to show you, I guess, where clinical trials come from and where they go to afterwards in terms of taking treatment forward. So there's the clinical trials in red in the middle. So where do clinical trials come from? So most clinical trials involve evaluating new drugs or new drug combinations, but where do they come from? So there's this whole pipeline, this whole process, which you may or may not be aware of, that results in a drug getting to the point where you can test it in a human clinical trial. So typically, this process starts with what I've described as blue skies research. So this is kind of sort of ivory towers stuff where some clever academic has some sort of curiosity about something with no idea at all where it's going to go, but just feel the idea is interesting, and very often this kind of research can result in practical outcomes, tangible kind of practical outcomes that the researcher never dreamed of. And unless you do that kind of research, you'll miss lots of opportunities for real sort of practical impact. And of course, this is the first type of research that hits the dust when funding is short, because its immediate impact is not clear to see, but it's fundamentally important. So everyone needs to support this kind of exploratory blue skies research. So the typically, for example, it would let's give a practical example. So it might, for example, discover that there's this protein called Bruton's tyrosine kinase that's really important in the biology of normal B cells, because if you don't have it, you've got this congenital condition called Bruton's hypogammaglobulinemia, where you don't make antibodies because you don't have B cells. And if you didn't do that sort of research, you might miss the fact that that's a really good protein to try and target therapeutically. But that was never done intentionally, trying to find a drug to treat CLL. Do you see where I'm going with this? So blue skies research is really important. Target identification, it's a bit of a sort of jargon mouthful term, but basically it means finding something to shoot at with a drug. Okay, so the drugs we use nowadays, they're by and large called targeted agents, meaning that they're intended to block, or they hit some sort of target that in this case the CLL cells are kind of addicted to or depend on. And if you take out that target, the cells just can't survive, and that's the basis of the treatment. So you've got to so you might come across that target by luck, or you might look for it specifically if you've got some idea about what the biology is of the condition. Okay, so you can then find something to shoot drugs at if you can then develop a drug. And that is the next step. It's actually developing the weapon, if you like, to shoot at the target. And again, this is a very complex business, and there are lots of different ways of discovering new drugs. And I'm not going to go through them all, partly because I don't understand them all. But the concept is simple. You need a kind of short list of chemicals that hits the target and does the job that you're looking for it to do. And the next stage then is to take this short list of chemicals and work out which ones might actually work if you put them into organisms like us. And there's all sorts of issues about how are they going to cause insurmountable side effects? Are they going to get to the right places in the body? Are they going to hang around long enough? All kinds of things. So there's a lot of work to be done around that to make sure to pick the right drug that you think is going to work in humans. And that's called preclinical drug development, before clinical drug development. And then once you've got your you've got your chemical that does all the right things, you can then, and you've tested it in animals to make sure there's nothing unexpected going on in terms of side effects in that setting, you're then in a position to start to introduce it into humans. And we've heard how there's a sort of sequence of clinical trials for having a sort of tentative look to getting more information to comparing it with standard treatments. Okay, so that's where kind of clinical trials come from. And then what happens after clinical trials are done, because if the clinical trial shows a positive result, in other words, if the new treatment it looks really good, better than the old one, you want to be able to use it. And there are a series of processes that need to be gone through to get you from the promising trial result to actually using it in patients. The first of those things is drug licensing. So, excuse me, I'll take another sip. So all drugs have to go through a very formal licensing process, and that's basically to sort of stop cowboy practice that could be harmful. And there's an organisation in the UK called the MHRA, Medicines and Healthcare Regulatory Agency. In Europe, it's the EMA. In the States, it's FDA. So to be used in those respective places, drugs have to be formally approved by those regulatory bodies. And they look at all kinds. They look at both the effectiveness of the drug and the side effect profile and make sure it's appropriate for that particular setting. And then if all goes well, the drug gets a license. But that's not the whole story, because then somebody's got to pay for it. And that's where NICE comes in if you live in England, and the equivalent organisations in the devolved nations. So in addition to, and NICE will only look at indications where the drug has a license. It's got to get the license first, and NICE can only look at it once it's got a license, and it can only look at it in that specific licensed indication. And it goes through the whole thing all over again, looks at how effective the drug is, what side effects it's got, but a third thing comes in to play, which is how cost effective it is. So you can have a brilliant drug, works like magic, no side effects, but if it costs an absolute fortune and would bankrupt the NHS, it's not approved. So there's that process to go through. So assuming the drug gets through, it's available, but then the final part of the process is knowing kind of where to use it if you've got options, and that's of course where guidelines come in. So guidelines can help sort of steer you one way or the other if you've got two options to choose from. So that's kind of how trials fit into the broader let's call it the drug discovery kind of pipeline. And now just a few words, because when we had a sort of pre-meeting about my talk, there was some interest in sort of understanding where all this research takes place and how the different sort of stakeholders contribute. So we've got the drug companies, we've got universities, and we've got the NHS organisers, hospitals basically. So which of those organisations does which bits of the research? So just to go through it briefly. So pharma companies are really good at certain things, and they've got massive resources at their disposal to do all the things that is quite hard to pay for in a non-commercial setting. So they're really good at sort of setting up pipelines to identify things to shoot at, basically. And they're really good at picking chemicals that can hit those targets, the so-called drug discovery. They're also really good at the bit immediately upstream of trials, making sure that those chemicals that they select do all the right things and don't kill animals and all the rest of it. And then the other thing they're good at is doing these very pragmatic so-called registration trials, where the aim at the end of the day is to get the drug licensed. And as we've heard before, we absolutely need the pharma companies in the process, otherwise we'd never get any new drugs. But they are accountable to their shareholders, and money does come into it. So they've got to get their drugs approved, otherwise the whole thing's going to be a waste of time for them financially. So the way the registration process works, this is kind of set by the regulatory agencies, and they would expect very kind of simple, pragmatic studies that just in very clear terms tell you that one treatment is better than the other. And that's kind of what registration trials are all about. And pharma companies are very good at that, because you've got simple protocols, they throw loads of money at it, get it all done very quickly. Okay, universities. So this is where the kind of blue skies research kind of takes place, where much of the research is driven not by the sort of need to come up with a drug at the end of the day, but by scientific curiosity. Some universities are really good at finding things to shoot at as well, and that sort of comes out of the discovery, the blue skies process quite often. You can work out where the Achilles heel is, if you like, of the cancer cells you're trying to kill off. Universities are also the only place you can do some clinical trials. So in as much as pharma companies are good at registration studies, they won't go near trials that are addressing more complex issues, because it doesn't really align with where they're going. So universities can do trials, for example, that look at sort of tweaking treatments, or maybe stopping them early. Like, static's a good example. You never get a kind of drug company doing that kind of study. And also maybe combining drugs from different companies together in a way that's really hard for drug companies to do themselves. So there's certain types of trials that sit particularly well in the university setting. So universities are also good at taking forward what we call trials methodology. In other words, how to do trials in the most efficient way possible, to get as much information from as few patients as quickly as possible. And they're leading the way on this kind of things. Very, very little of that goes on in pharma, because it's too generic. And then the other thing that non-commercial research is good at is so-called stratified medicine. What that means is basically accepting that a one-size-fits-all approach might not be best, and that everyone's different, and that to try and unpick that and work out which individual patients benefit most from which specific treatments, to sort of break it down and separate patients into groups. And that's the sort of thing that doesn't sit comfortably with big registration studies, where you sort of lump everyone together and get get your license. And then, as we've heard from Umair, health data research, this big data where you're looking at real-world evidence, that's the sort of thing that universities are better at. That said, there's a lot of overlap, and there's a kind of mutual dependence between drug companies and universities. And then, finally, the NHS. So, obviously, that's where the patients are. So the NHS is the only place where you can actually, in the UK at least, the only place where you can, deliver trials, where you can recruit patients, give them the treatment, follow them up, get the data. So the NHS plays an absolutely crucial role in this as well. And also, as we heard from Frank, that's where you can collect patient samples as well, which feeds into some of this other stuff I've been talking about how best to split patients into groups. You need the samples for that, and the NHS is where you collect those samples. And of course, the NHS data that Umair presented requires the NHS. That's where it's collected. Okay, so this is my kind of psychotherapy, personal psychotherapy slide, as a sort of primarily, what you might call an academic trialist. I just thought I'd share with you my kind of some of my experiences and perspective on trying to do big non-commercial clinical trials and what the barriers are. So the first barrier is money, as it always is, and the problem here is that trials are expensive, and there's not a lot of money around for them, and getting money for clinical trials is fiercely competitive. So right at the beginning, there's this sort of problem. And then there's a kind of expectation gap relating to that. So the funder wants more than their money can pay for very often, and that square needs circling, or whatever the correct term is. We really struggle with the sort of expectations of the regulators. So the whole sort of system of making sure trials are done properly, which is overseen by the MHRA, is really geared towards commercial trials that are looking at new drugs and heading towards registration. Those same rules are applied to non-commercial trials, which results in a very, very cumbersome and often inappropriate system where the sort of stringency that you're obliged to operate at, it almost becomes unrealistic within the funding envelope that you've got. And it can also become nonsensical as well. So, give you an example. So, in one of the trials I'm leading, it's a lymphoma, but it involves a drug called bendamustine that some of you may be familiar with. And bendamustine obviously has a number of side effects, among which suppression of bone marrow infection and what we call febrile neutropenia is really common. But the so-called reference safety information for this drug, so this is the document that you have to refer to. So if a patient in a trial gets a side effect, as the chief investigator, you have to decide whether that side effect is expected or not, and then if it's not expected, you have to report it. Okay. So the reference safety information for bendamustine has all kinds of things in it, like bone marrow suppression, neutropenia, fever, sepsis, blah, blah, blah. But the words febrile neutropenia are not there in that form. So so a patient has febrile neutropenia, you have to report it as unexpected, which is a complete nonsense. And adds all sorts of layers. And in the end, you literally can't see the wood for the trees because there's all these unexpected things, pseudo-unexpected things flying around that blind you to the really important things. So this is a real problem, and it's done for the best of intentions, but ends up being counterproductive in terms of what it's trying to achieve. And then there's, again, this is from a non-commercial perspective, that we have to compete with industry studies, and that's really hard because they have loads of money associated with them that the companies just throw at them. And the competition occurs at all levels. So for example, in the trials unit, we have a capacity issue with trials unit staff. So these are the trial managers and data managers and the statisticians, because industry are pinching them because they can pay them higher salaries. So we don't have enough people to do the coordination. You can have all your funding, but you can have a staff shortage, which means you can't deliver the trial because they're being hoovered up by industry. And then trial setup. So this is what happens in local hospitals. The R&D department in local hospitals has to go through a sort of a whole process to set new trials up. And this is fully funded through industry studies. So if you set up an industry study, a local hospital will get a big pile of money associated with that, and they of course say thank you very much. That'll do nicely. And to be fair, they can then reinvest it in paying for other things if there's a surplus. But it does mean that if you've got a non-industry study that doesn't pay as much, you're competing with. There's a financial sort of competition going on for prioritisation to set studies up in local R&D departments, and this can be a big challenge. And then, of course, you've got the recruitment. Sometimes the population of patients that you need is not big enough to have more than one study going on at the same time in that population. And if you've got an industry study directly competing for the same patients, it hoovers up all the patients because the hospitals that run those studies get more money for them. So running a non-industry study, you're faced with all these challenges. And then, just to extend my psychotherapy session, and this is because industry studies, you can get them done really quickly. You just throw loads of money, get them done quickly. Academic studies tend to take a lot longer to complete, partly because of the funding, partly because of the sort of questions they're often asking, which are just longer term ones. And of course, what can sometimes happen is that the standard of care can change either while you're recruiting, which means you have to change the protocol, otherwise you won't recruit any more patients if the entry criteria link into the current standard of care. And then, of course, even if you complete recruitment and the standard of care changed, the horse has bolted and you've got a trial that actually doesn't tell you very much because treatment's moved on. So this is really challenging, and what you need to kind of deal with all this, I've listed a few adjectives there. I can think of a lot more, which probably culminates in stupidity, but that it is a real challenge. However, it is worth it. It is worth it, and this is my final slide really, and I've just listed here some of the broader benefits of research. So clearly, trials are the main vehicle through which medical progress is made, and they allow patients to access new treatments that wouldn't otherwise be available. My picture's overlaying the next box, but it basically running trials in a unit like ours, I think, just drives good medicine and patient care. It engenders a culture of doing things properly, if you like. And I think we in the team very much believe in that kind of thing and the benefits, the sort of indirect benefits of doing trials. It also stimulates clinical leadership. Somebody's got to look after these trials, and that has a knock-on effect. It means that people, some of the sort of earlier career people can step up and acquire leadership experience that stands them in good stead for later. And it's good for staff recruitment. So people are much more likely to want to come and work in a place where there's a kind of dynamic research environment going on. So it's good for staff retention, good for staff recruitment, and also good for staff development too. And I guess from an organisational point of view, if you acquire a reputation for delivering clinical trials to a high level, that enhances your reputation and credibility, including with funders and people running the next generation of trials. So that sort of, if you like, creates a virtuous circle of having access to the next generation of trials and the next new treatment. So all these things, I think, are benefits of doing clinical research, and I hope you sort of share my view about that. So I think that's probably all I've got to say. Thank you for your attention. I hope that was sort of a little bit out of left field, but reasonably interesting.